Great, thank you. And so again, yeah, with with this setup, I can't see the participants nor myself actually. So if I'm doing anything goofy, let me know. So this talk came out of a presentation many years ago by Donald Mish and Lydia Weiser. And initially, it had to do with individuals who really had a lot of difficulty with self-regulation, and there's the objectives there, treatment decision-making models, rationale for limit setting, what facilitates or interferes with it. So the individuals oftentimes with difficult behavior management and self-regulation, borderline personality disorders, antisocial individuals, substance use disorders, and anyone can have a particular point in time where they really struggle more with treatment adherence. And the point it's important to make is it's not meant to be punitive. It's meant to be assisting people to manage the goals in which they came to us with. So also when I talk about individual providers, I may mention therapist and therapy. That's meant to be in general terms. I've given this presentation to physicians, to social workers, to nursing staff, et cetera. Same thing with the term patient. It can be used interchangeably with client. But when we even speak of, limit setting, it sounds quite unilateral. And so it's meant to be, treatment focused, not punitive. We always want to make sure that we're trauma informed. For those of you who may be a bit older, we used to get very pejorative with people with personality disorders. We would use that as a negative term rather than seeing individuals with certain personality disorders as clearly having had significant trauma in the past. And so we always want to be mindful of that. And, what we're talking about is essentially relationship and this having to do with clinical relationship. Very busy slide here, but just a reminder that, in the old days, so my father was a primary care doc, a general practitioner. And in his days, it was the doctor had the knowledge, told the patient what to do. Patient was supposed to follow through and be a good patient, which is really the traditional medical model or paternalistic type of approach. Shared decision-making is really, active participation between all parties. And both in terms of receiving information, sharing information is very much two-way. And the decisions are two-way. The informed type of model is really more the client or the patient, primarily being one way, being driven by the patient, coming in saying, this is the information I have, this is what I want to receive, et cetera. And there are times where all models are appropriate, particularly the traditional model, when people are in an emergent situation where the clinician has to take over because of significant danger. That certainly happens. So it's really, case by case. We need to be aware that these models can be used, but typically what we want to do is to land in the shared decision model as often as we can. So the rationale is to provide a safe or holding environment. And by holding, I mean, holding in a therapeutic caring sense. Consistency, responsibility, self-care. All behavior has consequences, both positive and negative, both for providers and for the patients or clients. And so we want to be mindful of that as well. Oftentimes as practitioners, we can do harm. When we collude with individuals, illnesses in a way that really isn't therapeutic, that can actually be damaging to patients. And so that's another reason why we need to be very cognizant of what the treatment plan is, what the goals are, when both parties may be overstepping bounds. And there are times where you cross that line briefly for good reason, you document carefully, but you always want to be aware of when that might be happening. So we're protecting the therapy, reducing boundary violations by both parties, reducing acting out by both parties, physically protecting the safety of the patient, the therapist, and others. And, oftentimes we talk about emotional currency. Currency is that which is in circulation, given, taken. And so it can be utilized to reach people's goals, but it can also be utilized at times in terms of manipulation, both from the practitioner and the provider and the patient standpoint. So, patient acting out oftentimes are overt threats, gestures, particular behaviors, paracommunication. We see that a lot with suicidality. It's extremely important that we are good at evaluating risk and knowing what language and behavior means with our patients. It's much more difficult when you're seeing a person for the first time or only time, and oftentimes then we are much more conservative. We may be able to feel a little bit more comfortable when we know the patient quite well in terms of our approach. And then there's covert acting out by patients, including missing appointments, payments, other sorts of distractions. Therapists or clinicians can also act out. Unfortunately, countertransference, you're probably well aware of that. The broad definition being unconscious and conscious emotional reaction to the patient. Glenn Gabbard has written a lot about, he's a psychiatrist, has written a lot about medical marriages. He's written a lot about relationships and communication with each other and patients. But he talks about the typical triad of a provider is we all have self-doubt, we all have guilt, we all have exaggerated sense of responsibility. And we always want to be cognizant of how we're approaching the patient, how we're feeling ourselves, self-awareness, whether or not that's getting in the way of our treatment, actually helping how we're treating patients, et cetera. Oftentimes, we find that individual practitioners who don't have the opportunity to bounce things off each other, colleagues. I used to be on the medical licensing board. I was also on the professional health program, which essentially in the old days was the impaired physician program, impaired physicians. So I was on those boards, and we would typically find that people who would get in trouble were really those who didn't get either feedback early from others, themselves didn't have limits set, or at least feedback on how they were doing. And also those people who were more alone and not only not able to bounce things off of other people, but other people weren't aware of their practices. And so they had no one to compare and give feedback to. So we always want to be cautious about that. So if you're practicing solo or have few colleagues to bounce things off of, it might be important for you just to set up a buddy system where you can, share things. So countertransference, again, sometimes we have over-identification with a particular patient. Sometimes we can be fearful of a particular patient, angry, even romantic feelings. Many therapists and providers will have all of these, but you want to be mindful of when they may be, coming up and when you might be experiencing these, and be able to manage those, and also to talk with colleagues about these. Where people get into real trouble is the predatory psychopathy, paraphilias, love sickness, masochistic surrender can happen by a provider in a relationship where they're just kind of giving themselves into a bad situation. Rarely for practitioners, individuals will have psychotic disorders, but it's certainly not unusual at all for practitioners to have mental illness such as anxiety disorders, mood disorders, et cetera. We know the general population, probably 1 in 5 individuals. It's actually the same with providers at least. And then there's the issues also of substance use, et cetera. And oftentimes, the employment situation, the work situation is the last place where problems come to fruition. So when a provider fails to adhere to an agreed upon treatment plan, or fails to remind the patient of the plan, and when it's not being followed, it may imply that the therapist doesn't care. They're not attending to it. They're not calling the patient on it. They're not acknowledging themselves that they're not following through. And so it gives the impression that the therapist might not care, or the therapist might not understand the agreed upon treatment plan, or that the therapist is incompetent. And so none of these may necessarily be the case, but certainly not paying attention to the patient and the plan being passive about it, or overly aggressive about it can certainly be problematic. Most of you have seen recently the data and the terminology on burnout. Christina Maslach has done the most research on it, and she came up with this triad of what makes up burnout. And remember that burnout is actually a systems issue. So it's not just an individual practitioner issue. It's when the system isn't working well. So that may be your own practice, it may be your parent organization, maybe other things. But and the terms that Maslach uses are kind of odd. You know, exhaustion we can understand. You know, physical, mental exhaustion in the workplace can be problematic. Cynicism, when we lose our empathy, when we become, they even use the term depersonalized, where we don't relate well to the client. We kind of are just going through the motions. Is certainly one of the factors that go into one of the elements of burnout. And then inefficiency, or essentially, you know, not feeling like we're doing our job, and sometimes the system gets in the way of us doing our job. In the medical model, oftentimes that's the electronic health record or others, but we may get so busy with filling out insurance forms or doing other sorts of things within the office that really aren't necessarily client care that leads to a sense of inefficiency. And one of the protective factors against burnout is actually, you know, discovering or rediscovering the essence of why you went into the practice. And so oftentimes, you know, when we're seeing these sorts of issues, those can get in the way. So essentially what we're trying to do in protecting the therapy is reducing chaos. We all know, if you've been practicing long enough, we know of those patients that if left to their current symptomatology, they will just continue to spiral out of control and shrapnel will go everywhere. And so particularly in those situations, it's important to help them gain self-control. There are times certainly when we have to step in and actually take control. Those are instances where we might, you know, end up with a civil commitment or things like that. But it's not unlike those of you who are parents, and I certainly don't want to infantilize patients, but we all recognize if we've had kids that they can get very tired, they can get very irritable, and they can get very chaotic, and not dealing with that doesn't help at all. It continues to allow that spiral to continue. And so that's part of the limit setting as treatment, is helping people learn to manage their own emotional regulation. So we always want to consider, you know, that what we're doing is reasonable care. And so we also want to be collaborative, and we also want to make sure that we have a good individual treatment plan. Sometimes when things aren't you know, going well, we haven't stepped back and really looked at the nuts and bolts and said, what is this that we agreed upon? And, you know, we're veering really far away from that. So let's revisit that again. You know, discussing issues, setting limits at the appropriate time, sooner in therapy versus later. You know, when people know what the agreed upon plan is and what particular behavior is going to be, you know, I shouldn't necessarily say tolerated, but at least understood. And that goes for both the provider and the patient, the client. The sooner that we see that and intervene, the better. An analogy I'll give is that I do teaching with medical students, residents. As I mentioned, I was on our medical licensing board, professional health program. When we would see practitioners with problematic attitudes and behaviors, we know that when we dealt with those very early on and helped to shape that behavior, it saved them, their patients, society, the burden of you know, not doing well farther down the road. And so again, when we're seeing patterns, we have an obligation to step in and assist. We also need to know our own limits. You know, what can my practice tolerate in terms of you know, how much change needs to occur or how much work I need to do? What about the clinic setting? You know, is the behavior currently occurring a safe place for the clinic? You know, it used to be the pattern was that patients would just get fired. We see that in primary care too. You're not quote unquote compliant with your treatment, so I'm going to fire you. That isn't what we're trying to do here. We're trying to look at this chronic disease management. We know that relapse occurs, looking out for relapse signs, red flags, trying to nip things in the bud as much as we can. And also recognizing that people will struggle, they will have difficulties, they will have relapses, but that's kind of built into our understanding and our treatment. One of the problems that's happened in years past was, particularly for prescribing and for controlled substances, was, essentially treatment contracts. And that the minute that a person, veered from the contract, boom, they got kicked out, they got fired. And we found in general, that's not real helpful. But we need to also be mindful of what's safe care, what's standard of care, and understand the chronic disease model as well. So we also don't want to set limits we aren't willing or able to adhere to. And so when we say, you need to, show up this, 100% of the time, or you'll be fired. That typically doesn't happen, but I certainly know of many patients who, they missed a couple of appointments, particularly in primary care, and they got booted out of the system. Or you'll see in the notes, Dr. So-and-so will no longer see this patient, et cetera, et cetera. So when we have a treatment plan, and when we have an agreement, particularly when there's difficulty with emotional regulation by the patient, difficulty with treatment adherence, and we determine that these are going to be the requirements for care, we want to make sure that we're actually able to adhere to that. And then always everything in context. I used to hear people say, well, this is how you treat quote unquote borderline personality disorder, or this is how you treat this individual, with borderline personality disorder. And then some life event occurs, which would throw any of us off. And then we say, no, we're absolute. And so everything has to be in context, including, our safety plans, et cetera. We have to be aware of when things are shifting. We also want to be aware as people move through treatment, and also for those of us who are involved in learning more information and education, this is the Prochaska and DiClemente stages of change. And we know that many people have comorbidities. They may have a mood disorder or a personality disorder, and at the same time, they have a substance use disorder. And we may want to know, okay, where are they in their behavioral change, their readiness for change in each of those areas, because oftentimes they can be completely different. Someone may be very interested in working on their trauma, but not so interested in working on their substance use issues. And, how do those interrelate? But also kind of being mindful of where they are and understanding these stages. When I was working with the state system, it was an eye-opener to our case managers. When they learned about stages of change, it helped them so much because they were so frustrated, both with the patients and themselves, when they weren't getting well. And they were throwing tons of resources in the wrong direction at individuals who weren't in a stage of change to be able to receive those. And so it was really a waste of time, waste of resources for everybody. Once they knew that a person was actually in the contemplation stage, their strategy would be different, their use of resources would be different. And it turned out to be very helpful, and they looked at the individuals much differently, as well as their own treatment plans. So one of the things that was helpful for me in years past was learning that the concept of defense or deficit. And I admit that it's not really a strength-based term, but it helped me when I was working with individuals who just weren't getting where I'd hoped they would be going, and they had hoped where they would be going. And so one question is, is the person choosing not to follow the plan, which they certainly have the right to do, or are they not capable of doing so because of their illness or some other illness? And then how does this change your approach? And I found for myself, I was certainly more willing to put in the extra time and effort when someone was really struggling with being capable of doing what they needed to do. versus somebody just saying, no, not going to do it, or, this is how I see the world, and I'm not going to follow the plan. And so, that concept at least was helpful for me, even though I know it's not necessarily strength-based language. We always want to be very careful when the rules change. So if you become frustrated with a particular patient and you just decide, I'm not going to do this anymore, I'm done with, with bailing this person out or blah, 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 it's really important that all parties are aware of when the rules change, particularly in a crisis situation. It's really dangerous when the rules change midstream and someone is, really struggling. So, oftentimes what you have to do is deal with it like you always used to. And once the person's in a safe place, then discuss the rule change, et cetera. But if someone is used to you coming to the rescue and you just decide out of the blue that's no longer going to happen, bad things might happen. You may have certainly agreed that I don't want to keep coming to the rescue like this. It's important that we change the plan, but it's kind of strike when the iron's cold as opposed to in the midst of a crisis. So potential problems with treatment plans include plans that are inconsistent, poorly defined, out of proportion, out of context, poorly timed, non-collaborative. And so again, when things aren't working well, sometimes we want to go back to the treatment plan and say, okay, do any of these apply? And it's also difficult to formulate a plan when you're constantly putting out fires. And so, that's another important reason for having things settle down, helping the individual settle down, having a safe plan to be able to do good formulation. And that's also why it's really beneficial to have colleagues assist in that as well, for you to bounce things off of individuals. So potential problems, again, lack of clear formulation of the case. We find that certainly in both psychiatry and in medicine, where we've been plugging away and things just aren't going well, and we have to step back and say, geez, maybe I have this wrong. Maybe this is the wrong diagnosis. Maybe this, is the totally wrong approach, and be able to step back and review that. Part of what I do currently, I don't do much clinical care, direct care, but what I do is collaborative care. And so I work with a federally qualified health center, and I review patient cases and their electronic health records, talk with the behavioral health manager within the primary care clinic, talk with the providers, and helping them to formulate a case and essentially go through and review where they don't have the time to do that. And so that's been very useful for them. Another potential problem in our care when things aren't going well is, do we have the clinical experience? Are we trying to tackle something that we really don't have the expertise in doing? And a lot of times it's because of lack of resources. Where else is the person going to go? One of my attendings used to say, are you trying to do the impossible here? So being mindful again about, why we're doing what we're doing, what the resources are. And again, that also helps in terms of that concept of burnout and it being a systems issue. Lack of instruction. I mentioned numerous times here, collegial feedback. So probably one of the most important things I learned when I was in training was, when you're stuck, expand the field. Even individuals who have solo practices, they should have colleagues that they can just call up and bounce something off of. And you can do that in ways that protect the health information. And we can actually do that today in terms of the model for ECHO oftentimes is a presenter does a didactics presentation. Then we have an opportunity for a case from the field where the identity is protected. So we're not, sharing information that shouldn't be shared, but talking about general concepts, and then, seeing where that goes. So a paradox is, we have these treatment plans. We need to be fair and consistent and willing to change. And we need to be, firm when we need to, but also plans should be changed when they obviously aren't working, when the client's needs have changed, when the therapist has made a mistake. We need to be flexible, firm and flexible at the same time. One of the Menninger brothers always said, when in doubt, be human. And so I always adhere to that as well. Oftentimes when we're looking at problematic behaviors, we're looking at the duration, intensity, frequency. Another term for that is manner and degree. How often is this happening? how egregious or how severe is this that has happened? So one place where you might fire a patient has been when there have been significant threats to yourself or staff at the facility. You aren't required to treat everybody. And so there are certain behaviors that are tolerable. There are certain behaviors that are expected. There are certain behaviors that are not tolerable. So when we document, we always want to document and think about, so what has been helpful, what hasn't been helpful in this longitudinal case. And when we document, we want to document how we're thinking about the case, why we decided to do what we needed to do, and if we have objective information to support this. There's a terminology in medical malpractice called negligence and omission of fact or omission of judgment. So omission of fact is when information was there or you should have reviewed it because it was available and you chose not to and something bad happened. Omission of judgment is much more forgivable by juries and by judges when we know that clinicians, are human, and we have reviewed the facts, we've done our standard of practice, we haven't deviated, and yet there was a negative outcome. That happens in healthcare. And so we want to make sure that, we do what is standard of care, that we aren't pejorative, that we document well. Sometimes when I've been on the fence and I've gotten colleague feedback and I've landed on a particular treatment decision, and I knew that it might not turn out well, I would document a bit more and just justify how I saw the situation unfolding and why I chose what I did. So you want to document as if the patient or client, the client's advocate, family member, attorney, or another clinician was reading over your shoulder. So you want to be transparent. Again, in the old days, we used to be nasty in the chart. We would be pejorative towards a particular person, particularly those with personality disorders. We would say not so nice things about them, and we don't want to do that. We want to be transparent. We want to be objective, and so we obviously want to be cautious about that. But as I mentioned, we're not obligated to treat everyone. If there's a particular emergency and an individual has no other option and you have the skills and training to do so, you should be stepping in. There are also the Good Samaritan laws, but not everybody can benefit from your treatment either, and not everyone needs your treatment. So, you can't abandon patients or clients. You can recommend transfer. You can point out why in your particular setting it isn't in their best interest, or at times yours, to have them in your clinic. But then you also typically have an obligation to assist them in finding other providers, unless the situation was so dangerous you really shouldn't have any other contact with them again. So again, in closing, we want to make sure that we have reasonable care. We understand what standards are in practice, be collaborative, pay attention to the treatment plan. And when you're stuck, you expand the field. And then you always want to take care of yourself personally and professionally. So I'm going to stop and see if anybody has any particular case from the field they wanted to discuss. Or let me ask you this, both Deanne and Marvin.
Yeah.
What was the reason that you signed up for this?
Feel free to unmute yourself or type in the chat.
No, Marvin's at CHI in Williston. Where was Deanne? I didn't hear.
Didn't see that.
Okay. It doesn't sound like we have any particular issues or cases that people would like to talk about.
Yeah. And just a reminder, we've got the links in the chat to complete, and if you haven't already done that. Oh, Marvin just said thank you.
You bet. Okay, good. And I just want to mention, so for me, this talk has actually been evolving. Early on, I was, kind of in the camp where we got to get these patients to behave, and and this out of frustration. And then clearly with more shared decision making, being mindful of individuals with trauma, chronic disease concept of relapse. It's very important to understand that occurs, and at the same time, we need to have good plans, being both firm and flexible for both ourselves and our patients. So, all right.
Thank you so much, Dr. McLean. That was great, and
right.
thanks for joining us today.
All right. Take care.
Yeah, bye.